So this is OBS and GYN 2024. The first question here, these are multiple choice questions. The surface of the ovary is covered by a single layer of squamous cells, cuboidal cells, columnar cells, ciliated columnar cells, mesothelial cells. So what makes up the epithelium of the ovary? What type of epithelium is it? Anyone to help? Okay. Thank you so much. It's a simple cuboidal. Yeah. So we can see here, this is the ovary, which is of course connected to the fallopian tube. And we can see the connection via this mesovarium. Now this epithelium of the ovary is known as a geminoepithelium. It's simple cuboidal, and then it's going to be connected, is going to actually continue as the mesothelium and then connect to the uterine tubes. The ovary has got other layers, so the outermost is going to be the same geminoepithelium. The inner layer is going to be the tunica albuginea, which is made up of dense connective tissue. And then you are going to have the cortex, and then you are going to have the medulla, which has got a lot of blood vessels. So the answer is cuboidal cells. Number 2 is saying female genital anatomy. Lymphatics from the uterus drain into para-aortic, iliac, and inguinal nodes. B. The round ligament provides the main support to the uterus. C. The ampulla is the narrowest portion of the fallopian tube. D. The uterine artery is a branch of the posterior division of the internal iliac artery. E. The levator ani muscle comprises pubococcygis, iliococcygis, and osteocavernosus. Anyone who can help with this one here? Okay. A. Sorry? Yes, doc. Yeah, thank you so much. I think that is important, especially for the cervix where the transition is happening, because that's where the cancer, cervical cancer starts from. So for this question, the female genitals, we want the true statement. So A is saying lymphatics from the uterus drain into the para-aortic, iliac, and inguinal. So you can see this here is showing the uterus and the vagina. Okay, the cervix is actually part of the uterus. So we can see that from the vagina, the lymphatics are going to go to the superficial inguinal nodes and the sacral nodes. That's from the vagina. Okay. Actually, mostly the vagina is going to the superficial inguinal. It is the cervix that is going to the sacral nodes. And then the cervix, besides going to the sacral nodes, is also going to the external iliac nodes. And then we have got now the body of the uterus. You can see the body of the uterus and also the fundus. The fundus is going to these nodes that are around the aorta, which we call the para-aortic nodes. And then part of the cervix, of course, as we said, from the internal iliac node, the others are going to the external iliac nodes, both of them. And then same also the fundus of the uterus, you are also having some of, the body of the uterus are going to the iliac vessels. So we are having the para-aortic, the iliac, and then the inguinal. That's the uterus altogether. Now B is saying the round ligament provides the main support of the uterus. The round ligament really is not the main support. The main support is going to be what we call the cardinal ligament. The round ligament is actually going to just be there to provide some support and mostly holding the uterus in position. Okay. And then C is saying the ampulla is the narrowest portion. The ampulla is actually the widest portion when it comes to the fallopian tube, with the narrowest portion being the interstitium. And then D is saying the uterine artery is a branch of the posterior division of the internal iliac. So here I've tried to put down the abdominal aorta. At the level of L1, we have got two in nice arteries coming from there. We have got the celiac trunk and the superior mesenteric, both of them coming from L1. Sometimes you see they'll put that the celiac is between T12 and L1. And then at L2, we are having those that are coming from the sides, the renal artery and the testicular in males or ovarian in females. Those are coming from L2. But also at L1 from the sides, because remember the superior mesenteric and the celiac come from the front and they're unpaired. On the side, you also have the inferior phrenic and uh, the middle suprarenal, the one that goes to the adrenal gland. Is the mid one. They also come from L1. And then at L3, you're having the inferior mesenteric. And then you have got the lumbar arteries, which are four of them. The fifth lumbar artery comes from a branch that comes direct from the between where the common iliac arteries are coming from. At L4, you have got the common iliac arteries, which will split or divide into the external and internal. The external, once it crosses the inguinal ligament, it becomes the femoral artery at the mid-inguinal point. And then the internal one is going to divide into the anterior branches and the posterior branches. Posterior, you only have three arteries, the iliolumbar, lateral sacral, and the superior gluteal. So it's only the superior that comes from posterior, the inferior no. And then from the anterior division, you have got some branches that will be going to supply the internal organs. Other branches actually supplying muscles. So those that are supplying muscles, we call them the parietal branches. And then those that are supplying internal organs are the visceral branches. So for the parietal branches, you have got the nerve, the artery to the obturator or obturator artery. And then you have got inferior gluteal. You can see inferior gluteal is from the anterior division. And then internal pudendal. Actually, all the branches coming from the posterior division are all parietal branches. Okay, so obturator, inferior gluteal, and internal pudendal. And then the visceral branches, we have got the middle rectal and the uterine artery. Besides that one, we also have the inferior vesicle. This is in males. In females, it's the vaginal artery. And then we have got the umbilical artery. Now, the umbilical artery is going to give rise to the superior vesicle artery, and then it would disappear. When it disappears, or when not really disappearing but obliterates, and then it will become the middle umbilical ligament. Okay, So we need to know these 11 branches of the internal iliac. The first three are coming from the posterior division, and then from the anterior division we have got obturator 4, inferior gluteal 5, internal pudendal 6, and then middle rectal 7, uterine 8, inferior vesical 9, and then vaginal 10, the umbilical 11. Okay, so we can see that the uterine artery doesn't come from the posterior division but from the anterior division. The levator ani muscles comprises the pubococcygis, iliococcygis, and ischococcygis. When you look at the levator ani muscles, the levator ani muscles make up what we call the pubic the pelvic diaphragm. Now we have the pelvic floor and the pelvic diaphragm. The floor is made up of many things, including muscles and all other structures that are supporting the contents in the abdomen and the pelvis. Now, specifically, the pelvic floor is referring to a group of muscles. Okay, so the pelvic floor is going to have muscles like the coccygeus and then the levator ani. And you can see the levator ani, you have got pubococcygis, puborectalis, and then iliococcygis, those three. But for the one here, they included ischiocavernosus, which is not part of the levator ani muscles. It is pubococcygis, puborectalis, and iliococcygis. Okay, so that is that. Hope that's fine. Question 3. Anatomy of the female external genitalia. A. And by the way, the levator ani is the most important muscle that forms the pelvic floor to support the internal organs from prolapsing. Anatomy of the female external genitalia. A. The ducts of the skin's gland drain into the urethra. The labia minora does not contain. So the answer for question 2 is A. So the lymphatics from the uterus can go into the parietic, iliac, and inguine. So which one of these is true about a female external genitalia anatomy? The ducts of the skin's gland drain into the urethra. The labia minora does not contain erectile tissue. The labia majora are homologous with the male penis. The external urethromeatus opens into the vesicle. The ducts of the Bartholin's glands drain into the upper two-thirds of the vagina. Anyone who can help with this one? Anyone? So question 2, the answer is A. Sure. Anyone to help with question 3? Which statement given is true about the external genitalia anatomy? Which one? Oh, the external urethromeatus opens into the vestibule. Okay. Thank you so much. Would you want to explain? Okay. Thank you so much. Yes. So when we look at the female, the external genitalia, we have got two main parts for the external genitalia. We have got the vulva, And then we have got the vestibule. So the vestibule is basically this space here. Oh, we can't see that color. So the vestibule is this space, this one. And you can see we have got the vagina posteriorly and then the urethra anteriorly. Okay. And then we can see that on the sides of the urethra, you can see this small dot here, this small dot here. Those are the skin's glands. So the vulva is made up of going to be made up of the labia majora. The labia majora is homologous to the male scrotum. We also have the labia minora. Okay, this one is the one that is now going to be closing the vestibule. And then there's the clitoris. The clitoris is formed of erectile tissue, which is known as the corpora cavernosa. Okay, this is actually known as the male penis, the clitoris. And then we have got the Bartholin's glands, which are also known as the greater vestibular glands. Now, the Bartholin's glands or the greater vestibular glands are going to secrete a mucus-like substance that is going to be uh, involved in sexual arousal. And these ones will be found on the sides of the vaginal orifice. Okay, like you can see this come a small opening here and also here. So the skin's gland are on the sides of the urethra, while the Bartholin's gland openings are on the sides of the vagina. And then you have got the skin's glands, which we also call as the lesser vestibular glands, because the Bartholin's are the greater. Now the skin's glands are homologous to the male prostate gland. And these glands, what they do is that they secrete a substance that is involved in lubrication. So to lubricate the urethral opening. Okay. So it's also believed that whatsoever that is going to come from this skin gland is going to have some antimicrobial effect. So this is the anatomy of the external genitalia. So A is saying the ducts of the skin glands drain into the urethra. They don't drain in the urethra, but they open on the sides of the urethra to drain in the vestibule. Labia minora does not contain erectile tissue. So the labia minora will actually do contain erectile tissue. Okay, together with these are the places that are going to be enclosed with blood for the female erection to happen. And then C is going C, the labia majora are homologous to the male penis. So this one is homologous to the scrotum, not really the penis. The male penis is the clitoris. The external urethral meatus opens into the vestibule. Yes, okay, this opening here together with the vagina. The ducts of the Bartholin's glands drain into the upper two-thirds. Or we have D. The external urethral meatus opens into the vestibule. So this one is true, isn't it? Okay, so this one is true. The ducts of the Bartholin's glands drain into the upper two-thirds of the vagina. Now you can see the ducts of the Bartholin's gland actually drain in the lower third instead of upper two-thirds. It's the lower third of the vagina. Okay, hope that makes sense. And then question 4 is saying the most important muscle in the pelvic floor is bulbocavernosus, ischiocavernosus, levator ani, superficial transverse perineal muscle, deep transverse perineal muscle. We had mentioned this one on the previous question. Which one is the most important muscle of the pelvic floor? Yeah, thank you so much, Doc. The levator ani. Okay. So again, this is a comparison. Pelvic floor and pelvic diaphragm, as we said earlier. The pelvic when we say floor, it is a broader term. It will include all the layers of the muscles and connective tissue at the base of the diaphragm. This is specifically the pelvic diaphragm. Now, the pelvic diaphragm itself is just a specific deep and large muscle group. So when you look at the components of the pelvic floor, you have got the pelvic diaphragm, and then you have got the perineal membrane, the deep perineal pouch, and then the superficial perineal pouch. The pelvic floor is just made up of the levator ani and also the coccygeus. Okay, these two muscles. You can see, like in this picture, this is how the pelvic floor is, like hands holding something. So the pelvic floor is going to hold these guys, the pelvic organs and the intra-abdominal organs from prolapsing. And you can see you have got the levator ani, iliococcygeus, pubococcygeus, puborectalis. If you include the coccygeus, now that will make the pelvic diaphragm. But of course, you have other muscles making up the pelvic floor. For example, the obturator muscle, okay, and then you have got these things like piriformis and such. Number 5 is saying the main support of the uterus is provided by the round ligament, the cardinal ligament, infundibulopelvic ligament, integrity of the pelvis, the broad ligament. We also mentioned this one. Which one is the main support of the uterus? Yeah, thank you. So this one is the cardinal ligament. When you look at the support of the uterus is going to have a lot of ligaments that will be attaching it in place. For example, you have got the cardinal ligament, also known as the Macarote's ligament or the transverse cervical ligament. It's on the sides, that's why it's called transverse here. Okay, that's the cardinal ligament. It's a main one supporting the uterus. Okay, we also have the uterosacral ligament. So it means that the cardinal ligament holds the uterus in the on the sides, and then uterosacral ligament. This one is the one that will hold the uterus to the posterior aspect. We also have the pubocervical. Pubocervical will hold it in the anterior aspect. Think of uh, the cervix being much in front than the uterus. Okay, pubocervical. We also have what we call the broad ligament. Now, it's actually inside. The broad ligament is a double layered fold of peritoneum. It will attach on the sides of the uterus and then to the lateral sides of the pelvic wall. But the broad ligament contains other ligaments in it. For example, it contains the round ligament of the uterus or ligamentum teres of the uterus. If you just say round ligament, you also have the round ligament of the liver. Okay, so please be specific. And then you also have the ovarian ligament. So all these ligaments are present in the broad ligament. Now the broad ligament is further going to be divided into different parts that to maintain the uterus. For example, mesometrium, mesovarium, and then you have got the mesosalpinx. So the round ligament itself is going to extend from the uterine horns, and then it is going to go, and we know this guy actually enters the inguinal ligament in females. I mean the inguinal canal in females. And then the ovarian ligament also, that will be able to attach to the ovaries. Okay, so those are the ligaments. Of this, the most important one is the cardinal ligament. Number 6 is saying the karyotype of a patient with androgen insensitivity syndrome is 46XX, 46XY, 47XXY, 45X0, 45XY. Anyone who can help with this one? Anyone? So in the karyotype, in the androgen insensitivity syndrome, Okay, thank you so much. Yeah. So androgen insensitivity syndrome, you have got someone who is genetically a male. There are others, their genetics actually, these are going to be female. They are going to have female features really, but in this condition, someone is genetically male, meaning that they have got XY. But instead of having 47, 40, how many chromosomes are supposed to have? Yeah, actually, they have got a normal 46 chromosomes, XY. But then the problem is that they cannot, the tissues cannot respond to androgens, which are the male sex hormones. So these people are going to have the female characteristics in androgen insensitivity syndrome. Okay, there are these female characteristics. So it is 46XY, but then the cells or the tissues cannot respond to androgens, leading to the features of a female. Number 7 is saying luteal phase deficiency has inadequate luteoprogesterone production, has inadequate follicular estrogen production, can be corrected by estrogen, associated with delayed menstruation, can lead to hypoprolactinemia. Any thought on this one? Any thought? Okay, thank you so much, Doc. Why do you choose that one? Yeah, thank you so much. Yes, so we know the phases of the endometrial cycle or the ovarian cycle. Actually, this is specifically for the ovarian cycle. The luteal phase is the phase that produce corpus luteum is what produces progesterone to try to maintain pregnancy. Actually, the luteal phase is the constant phase of the menstrual cycle. Others might vary. It's for 14 days. So, if you don't have the luteal phase, it means that you can't produce the progesterone, so it's going to be inadequate. Number 8 is saying which of the following is the primary source of estrogen? Thicker internal cells, thicker external cells, granulosa cells, interstitial cells, epithelial cells. Any thought on this one? Any thought? Okay. Is there any other thought? So the good doc has picked C. Okay. So there is what is known as the two-cell mechanism. And in this mechanism, actually, when you look at the ovary, it has got these follicles that are different phases. But if you just pick one follicle, the follicle is going to have layers. The outermost layer will be the thicker external, a bit inside is the thicker internal, and then you have got the granulosa cells, okay, and the other components. So what happens is that The thicker interna, not externa. The externa is basically more connective tissue. Thicker interna, they have got receptors for luteinizing hormone. Please take note. And what happens that this luteinizing hormone is going to come and bind on them to stimulate them to start making androgens. Specifically, the thicker internal cells will make the male androgens. Okay, specifically which ones? Androstenedione and also testosterone. But then they do not have the enzyme that can convert these male androgens to the estrogen. So what happens that when follicle stimulating hormone binds on granulosa cells, that then is going to stimulate the granulosa cells. Okay, and then they are going to use the enzyme aromatase. So aromatase basically is going to be activated or stimulated once follicle stimulating hormone attaches to the granulosa cells, and then this aromatase is going to convert the testosterone and the androstenedione to form estrogen. Now, specifically, the type of estrogen we are forming here is the estradiol, which is the most potent form of the estrogen. So that's what happens. So the question is, where does estrogen come from? It's actually from the granulosa cells. Okay, and take note of the hormone. It's follicle stimulating hormone stimulating the granulosa cells. Number 9 is saying the menstrual cycle. A. Follicle stimulating hormone acts on thicker cells of the ovarian cycle of the ovarian follicle. B. The duration of the luteal phase varies greatly. Yes, doc. It's yeah, it's C. Sure. So the menstrual cycle, follicle stimulating hormone acts on thicker cells of the ovarian follicle. B. The duration of the luteal phase varies greatly. C. Estrogen is the predominant hormone during the secretory phase. D. Prostaglandin F2 alpha causes vasodilatation in the endometrium. E. The luteinizing hormone surgery results in the resumption of meiosis prior to ovulation. Any thought on this one from anyone? Any thought? Okay. So we had already described some of these. Follicle stimulating hormone acts on the thicker cells. We already said that follicle stimulating hormone acts on granulosa cells, so that option is out. B. The duration of the luteal phase varies greatly. And we said that the luteal phase is actually the one that is constant, 14 days. It doesn't vary unless the other phases. Okay. And then we have got these other three options. So for us to understand them, let me just go through an overview of the menstrual cycle. Now, the menstrual cycle is made up of what is happening in the ovaries and what is happening in the uterus. So I've got the ovarian cycle and the uterine cycle, or the endometrial cycle, and these guys actually uh, correlating. The first phase, of course, is not in a specific order, but in this case, we've started with the follicular phase. Follicular phase will happen between day 1 to day 14 of the menstrual cycle. And what happens in the follicular phase is that you have got a follicle stimulating hormone from the anterior pituitary gland that is going to come and stimulate follicles to start developing. So what happens is that each month 15 to 20 primary follicles are going to be recruited because of this follicle stimulating hormone. And these guys will start growing, but only one of them will actually get to grow and mature. Okay, one is going to win. And that one that wins is the mature follicle, the secondary follicle. And what happens is that the dominant follicle or the mature follicle is going to start producing high levels of estrogen. And this estrogen, once it gets to be produced, is the one that is going to trigger the release of the luteinizing hormone. Where is the estrogen coming from? From the maturing uh, follicle. Specifically from which cells? The granulosa cells. Okay. So by the 14th day, when estrogen has reached a very high point, it will cause a surge. There will be a release of luteinizing hormone that is on the 14th day. So that leads us to the second phase, which is ovulation, which is happening on the 14th. Okay. So on the 14th, the peak in estrogen is going to trigger a massive surge in luteinizing hormone to be released from the posterior pituitary. Actually, it's from the anterior pituitary gland. And what this is going to do is that to signal now the oocyte, because each follicle contains an egg in it. So once the follicle matures, it's supposed to release this egg which is in it. So that is what's happening. Once luteinizing hormone is released, it's going to signal the oocyte, which is the egg, to complete the first meiotic division. In females, what happens is that uh, by the time the woman is being born, or the lady is being born, she has got about 2 million of these eggs. And then what happens that these eggs are going to be arrested at birth. They don't complete meiosis because meiosis was actually happening in the uterus. And at birth, meiosis is arrested specifically in prophase 1. That's the first arrest. And in this prophase 1 specifically, we call it the diprotein phase. Okay. So the diprotein phase, that's where the arrest is happened. And this is at birth. So what happens that when menstruation starts, that mature follicle that has been released, it is now going to leave that first arrest, which is prophase 1. And then once that happens, it's going to leave that prophase 1. That is happening when the surge in luteinizing hormone has happened. So this guy, before the secondary follicle is actually released, it is first going to complete the first meiotic division by moving out of prophase 1. And then it is going to be released into the fallopian tubes. So it can stay 12 to 24 hours before it can die if it is not fertilized. And that will lead us now to the luteal phase, which is the second one, from the 15 to the 28 for a 28-day cycle. If the cycle, let's say, is 30 days, you can calculate how long the luteal phase is going to be. Okay, by simply saying actually the luteal phase is supposed to be constant 14 days, but you can calculate the other days, like for example the follicular phase, how long it will take by simply removing 14. So what happens at this point is that when ovulation has happened, the point where the egg was in the follicle is going to remain as a corpus luteum, and this will start releasing a lot of progesterone in an attempt to because it's thinking pregnancy might happen, so to try to maintain the pregnancy. Okay. And of course some few progesterone, but progesterone is really, I mean, some few estrogen. When you have got a lot of progesterone, it's going to go to the anterior pituitary and inhibit the release of follicle stimulating hormone and luteinizing hormone. And at this point, what happens is that the egg is going to be arrested again, the same mature egg. But in this point, it is arrested in what we call metaphase 2. The first arrest was in prophase 1. So the egg will only move out of metaphase 2 when it undergoes fertilization. Otherwise, any egg that is released, okay, during the shedding of the uterus and the ov and what happens every month is actually the egg that is in meiosis in meiosis 2, specifically metaphase 2. So that is what is going to be happening on the ovary. And these events are actually corresponding to what is happening to the uterus. What is happening to the uterus? The first thing is, for the first 5 days is known as the menstrual phase. Okay, so you take it back from the from the previous month or the month before this one we are discussing. So what happens is that, remember, uh, in the luteal phase you have got progesterone, but within 14 days, if there is no implantation, this corpus luteum will stop producing the progesterone. So there's going to be withdrawal of the progesterone and the estrogen. And that is what causes the degeneration of the corpus luteum. Okay. When that happens, when the corpus luteum degenerates, there's going to be release of the prostaglandin F2 alpha. And this is a vasoconstrictor. If it constricts, it means that there's going to be no blood supply to the endometrium, and that causes ischemia and the shedding off of the functional layer. It's only the functional layer because the basal layer remains. Okay. And then the next phase is going to be the proliferative phase, which is between day 5 to day 14. So the wall of the uterus will start now regaining, because at this point estrogen is rising again, and this is corresponding to the follicular phase where estrogen is rising again. Okay, this rise in estrogen is actually what is causing the endometrium to start proliferating. And then the next phase will be the secretory phase, that is from the 15 to the 28, and this is corresponding to the luteal phase. This is driven by high levels of progesterone in the luteal phase. That's why you have got this the gland dilating, the blood vessels dilating, they become more tauseous to bring more nutrients, okay, to this area. So these are the phases of the menstrual cycle. So we can see for options C, it says estrogen is the predominant hormone during the secretory phase. Is that true or not? What do we feel about that option? Is it true or false? So estrogen is going to be predominant in the follicular phase of the ovarian cycle or the proliferative phase. In the secretory phase, what is high is progesterone. And then the prostaglandin F2 alpha causes vasodilatation. That's false because it causes constriction. He's saying the luteinizing hormone surge results in the resumption of meiosis prior to ovulation, and that's true. Okay, the resumption of meiosis because of the first arrest. Number 10 is saying characteristics of the vaginal discharge for bacterial vaginosis is discharge is clear. Yes, doc. Yes, the thicker antenna. Sure. So characteristics of the vaginal discharge for bacterial vaginosis is discharge is clear, pH is between 4.5 to 7, consistency is curdy, it is positive for chlamydia. What do we think about this one? Which feature is true about BV, bacterial vaginosis? So on question 9, the answer is E. The surge in luteinizing hormone will result in resumption of meiosis, specifically meiosis 1 from prophase 1, because that's where the arrest was. Okay, so anyone to help with this one? A feature of bacterial vaginosis. Anyone? Okay. Okay, thank you so much. So let's just get to review BV. Now, BV is caused by, we call it, uh, what's the term? There's a specific term. Uh, there is this balance or imbalance between the normal flora or the vagina and then the anaerobes. Okay, please take note, not aerobes but anaerobes. So there's actually dysbiosis between, there's going to be a shift from the normal flora to the, what's the normal flora of the vagina? It is the lactobacillus. These guys are going to decrease, and then you are having these anaerobes increasing. And the most important one you need to know is Gardnerella vaginalis, also known as Haemophilus vaginalis, with other anaerobes like Mycoplasma hominis, Ureaplasma, Urealyticum, Streptococcus viridans, and then the other species that are anaerobes. Okay, so that's a problem. The anaerobes have increased, lactobacillus has decreased. What are the risk factors? Recent antibiotic use. You know, antibiotics destroys literally everything, including normal flora. Decreased estrogen production of the host. Wearing an intrauterine uh, device, contraceptive device. Douching. Women who like washing their vagina with a soap, with water, you are removing all these bacteria which are supposed to be protecting you. Okay. Intravaginal hygiene products, liquid soaps, presence of other STIs like trichomoniasis, and also other conditions like cigarette smoking, obesity, being single or not married. And you can think, why is that one a risk factor? And then prior pregnancy, history of induced labor. And then you have got sexual activity like high frequency, multiple sexual partners, having new sexual partners, early initiation of sexual intercourse. So for the clinical features, you are going to see a creamy vaginal discharge. And this one, what's important is homogeneous, like it's the same. Okay. Or we describe the discharge as grayish white. One important thing is it is actually going to be adherent to the vaginal wall. Another important feature of BV is that the you are going to have this bad smell which is fishy, and it is more especially after sex. That's when it's going to be more prominent. So the other clinical implication actually in pregnancy is that this BV can actually lead to preterm premature rupture of membranes, and then preterm labor and chorioamnionitis, which is just infection. Other complications of BV include PID, vaginal calf cellulitis. You can also have pregnancy complications like a second trimester miscarriage, prom, preterm birth, endometriosis. By the way you diagnose this condition, you use what we call the cells criteria. So this looks at four things. The first thing that you look at is the homogeneous vaginal discharge, which is of course grayish whitish. The second thing is the pH. The pH is more alkaline because these anaerobes actually produce ammonia. Okay, they produce ammonia. That is why it's alkaline. And that is why another test besides the pH greater than 4.5 is that you're going to have a positive WIFO test. And for this WIFO test, it is basically a fishy smell, which is because of the amine. Okay, amines, remember, the same bases. And what happens is that when you get this discharge and then you drop uh, a drop of 10% potassium hydroxide, then you are going to have the production of these amines, and then there is this fishy smell. That is a whiffle test, which is positive. The last feature is the presence of what we call clue cells. Okay. So here again, what you do is you get a smear of the vaginal discharge, and then you drop some normal saline there on a glass slide, and then you see under a microscope. If you see greater than 20% of these clue cells, that is going to be diagnostic. So you need the 3 out of 4 of these features to diagnose. So for the treatment of bacterial vaginosis, metronidazole and clindamycin, these two drugs are the important ones. You have got other infections of the female genitalia, and the features that you use, for example, like the cause for BV, the cause is the outgrowth of the aerobes. For candidiasis is candida, trichomoniasis is trichomonas vaginalis, and then you have got chlamydia, where is chlamydia trichomatis, and then gonorrhea, where I've got Neisseria gonorrhea. So the discharge in BV is thin gray, okay, the grayish whitish. In candidiasis, it is a thick white, like cheese, coated cottage cheese. In trichomoniasis, the discharge is greenish yellow. Please take note. While in chlamydia, it is usually watery or cloudy, and in gonorrhea, it is yellowish, creamy, or bloody. That's in gonorrhea. The order is fish in BV, and in candidiasis, there might not be any order, and then in trichomoniasis, it may be just a foul order, and then for chlamydia and gonorrhea, you may or may not have any order. And then you also have things like itching. In BV, the itching is not that much, and then in candidiasis, the itching is a lot. In trichomoniasis, there's also a lot of itching. In chlamydia and gonorrhea, the itching might not be there. Okay. You also have pain. In BV, the pain is not really there, including candidiasis. And then in trichomoniasis, you are going to have vaginal soreness, okay, even pain during urination, dysuria. And then in chlamydia and gonorrhea, there is going to be also pain during urination, including also the lower abdominal pain. So pain in the abdomen, you can be suspecting PID, because those are the causes. Bleeding is not normally there in BV and in candidiasis, and also in trichomoniasis, but they can be bleeding in pelvic inflammatory disease caused by these two, chlamydia and gonorrhea. And then another thing is that in trichomoniasis, you can have dyspareunia, pain during sex, including also in pelvic inflammatory disease by these two, chlamydia and gonorrhea. Okay, so we can say that the best option for our question, therefore, discharge is clear, is false, because it's actually whitish, grayish white. Has a yeast smell, again that's false because it's fishy. pH is between 4.5 to 7, this is true. Consistency is KD, it's not really like KD, this one is actually homogeneous. When you're talking about the KD, then we are referring to, that's the trichomoniasis. And then it is positive for chlamydia, not chlamydia but Gardnerella. Okay, so that is that. I hope we've at least reviewed that. The card is candidiasis, not trichomoniasis. Number 11 is saying, yes, doc. The answer is the pH between 4.5 to 7, the alkaline pH. Sure. 11 is saying the complete more results from fertilization of a haploid ovum by a haploid spermatozoa, fertilization of haploid ovum by two haploid spermatozoa, fertilization of an empty ovum by two haploid spermatozoa, fertilization of an empty ovum by haploid spermatozoa, fertilization of haploid ovum by an empty spermatozoa. What do we think of for that one? Anyone to help? Okay, so the dog thinks C. How about others? Would you want to explain?
From what I was reading, in the research I was reading, I'm a bit confused between C and D, but I know that in complete no, there's an empty ovum. So it can either be caused by this empty ovum being fertilized by two stems, which will lead to a diasteme, or it can be by one stem. So I'm not quite sure between C and D, but I was thinking it's C. To ask is so more confusing.
Okay, well, thank you so much. Is there anyone with another thought? Any other thought? Let's feel free.
The,
Okay, why do you go for that one, Doc?
that's how I remember it.
All right. So when we look at a complete mo and an incomplete mo, we are going to be comparing the egg and what is fertilizing those eggs. For example, in a complete mo, also known as the complete hyadatiform mo, you have got an empty egg. So you basically have no maternal chromosomes. It is fertilized by either one or two sperms. So the paternal genetic material is going to be able to duplicate. So meaning that the offspring is literally whatsoever that is being formed is going to be just having maternal DNA. So in a complete mode, the fetus can't really even form. So no fetal tissue is going to form really. Okay. And the placenta is going to be abnormal. The size of the uterus is going to be really large for the gestational end. So this is the cause of post deaths. When you measure the levels of beta HCG, they are going to be really high. The signs and symptoms you see in this patient are going to have things like severe nausea and vomiting, and you can also have preeclampsia. Okay. But when you look at the incomplete more, here is the fertilization of a normal egg, which contains maternal chromosome by two sperms. So the result is going to be a triploid, which is this 69 chromosomes. Yeah. Here you can see some fetal parts or a non-viable fetus, but at least it's different in that you can see some fetal parts. The uterine size might be normal for the dates, different from the other one where it is post date. Hope that's okay. So for our options, it's fertilization of haploid ovum by, so it's supposed to be an empty ovum by two haploid sperms. So you can have two of them, or you can only have one haploid sperm. Okay. So what's why? So we have got C and D, and then this saying fertilization of an empty ovum by a haploid sperm. Okay, the one that is on top is saying specific. It has given us a specific two. So why do we think like why should we go for C and not D for this one? Anyone with a thought?
Again, sin is more open. For people who have the bad it's more likely.
Okay. Thank you so much. So the doc
One of
says,
the sources that I also
yes, doc.
like, like one of the sources I came across is that if it is fertilized by the system, it has to have already duplicated, so it's supposed to be organic.
Okay. Oh, I hope we've gotten what the doc has said. Right. So our best option is going to be option C. So the fertilization of an empty egg by two sperms. So what happens is that a complete had for more. When you have got one sperm, like for one sperm, it is going to duplicate as the doc has said, or you can have two different sperms. Okay, that will lead to diploid. Because if two different sperms get to come and fertilize the egg, it will still form the genetic information being diploid. For one sperm again, it still duplicates itself. That will still result in the 46 chromosomes. Okay. Number number 12 is saying in a threatened abortion, which of the following items is true? Cervix is open, evacuation is the best treatment, all patients should be admitted. In the majority of cases, pregnancy will continue without any complications. Does not necessitate giving anti-D for rhesus negative mothers. What do we think on this one? Any thought? Okay, so abortion is the expulsion or extraction of the embryo or the fetus from its mother before the age of viability. For the WHO, it's 24 weeks. In Zambia, we use 28 weeks. We can also define abortion as the expulsion of the fetus or embryo weighing less than 500 grams. Okay, so that's abortion. Now, abortion can either be spontaneous, we call it a miscarriage, or induced, that's a deliberate one. The one that induced can be either legal or illegal, which is unsafe, and most is going to lead to sepsis, so septic abortion. For the spontaneous, it can either be isolated or recurrent. The recurrent one is where it's repeating at least more than 3 times. Now, the spontaneous abortion can either be threatened, inevitable, complete, incomplete, missed, or septic. Of importance when you look at these ones, for the threatened abortion, the the internal os or the cervical os is actually going to be closed. Okay, and then someone is going to have pain, they are going to be bleeding. The fetus is viable. Really, the fetus is viable. But then it's just that the conditions are not right. The fetus can never survive. That's a threatened abortion. That's why the best thing that you want to do is to evacuate. Okay, to evacuate this fetus. The inevitable abortion is where actually the threatened, the one I'm from mentioning is the inevitable, where you can't do anything, where you want to evacuate. The threatened is even from the word is threatened, the os is closed, but someone is bleeding. There is chance that they can actually lose this child, but then a high chance is they can actually save the child because the os is closed and the child is alive. Even if you do ultrasound, you can still feel the child. But the inevitable, the os is open. So whatsoever that you do is futile. This child is going to come out. Actually, even the child is non-viable. Okay. So what you can just do for this one is evacuate. That's the best thing you can do. Just evacuate the uterus. For complete abortion is the child has already moved. The child is already come out and the cervix has even closed back. Okay, even the pain is resolving. When you do ultrasound, the uterus is actually empty. For missed abortion, again the os is even closed. The mother didn't know that they lost the child. Okay, the even the features, the symptoms are actually not there, but then you don't have any child. When you do ultrasound, you discover that the fetus died. So when you look at the most common causes of miscarriages or these abortions, in the first trimester, the commonest are genetic factors like chromosomal abnormalities. And then you have got endocrine disorders like thyroid and diabetes. You have got immunological disorders which can be autoimmune or alloimmunity, and then infections, and then others that are unexplained. In the second trimester, the problems that are causing abortion is anatomical anomalies, for example, cervical incompetency, which can be in congenital acquired, and then you have got Mullerian fusion defects, for example, a biconeate uterus, septate nucleus uterus. This is happening in the second trimester, and then uterine synechia. You can also have uterine fibroids, maternal medical illnesses, and some other unexplained conditions. Those are second trimester problems. So, back to our question here, we want what is true about threatened abortion. Okay, so for the threatened one, the cervical os is open. Is that true? So, we said the os is closed, isn't it? The inevitable is where you have got open. Evacuation is the best treatment. All patients should be admitted. Now, this is just threatened, so it's not like all patients should be admitted and you evacuate. How about it's just the threatened, the child is still okay. In the majority of cases, pregnancy will continue without any complication, does not necessitate giving anti-D or rhesus negative for rhesus negative mothers. So you're supposed to give anti-D because you can actually, because it's threatened abortion, some blood can actually mix with the maternal blood, and then you are going to produce the antibodies against the rhesus antigen. So you need to give the anti-D. So for me, I would go with D. In the majority of cases, pregnancy will continue without any complications because it's just threatened. If it was the inevitable one, there's barely anything you can do. Is there a different thought on this question? Okay. Yes, Doc.
How about go to question 11? Well, I was actually checking this one.
Mm-hmm.
Yes, I was checking just to confirm. So, I completely like. So, what I've found is that fertilization of an embryo that does not carry any chromosome by female sperm, which is the haploid chromosome, is said contributed by the sperm. Yes, that's definition. And the karyotype is 6XX. Then for a partner, it's where there's fertilization of the embryo by two sperm, which is a hap, yeah, where there is a haploid over mix, if the patient is a cartel haploid set in a single stem, and the karyotype is okay, 9XXY. So, with, with, with that, what is the best answer here? How's this the trying to compare that?
Okay. Hmm. It's something that we can.
Just
Yes, doc. Okay. It's something that we can look at again in case there are more things that we should be able to we might have missed on a complete more. Because for a complete more, it's the genetic makeup is actually going to be diploid. Okay. But sometimes you so normally you can have depending with the sperm that has the if you have got one sperm or two sperms, sometimes someone can have 45XX, 46XY. So in other words, it's diploid. But for the partial more, it's the one that is triploid. That's why you have got the 69 chromosomes because you have got some which are extra. But I think we should be able to check more from the textbook instead of. So I'm going to come back to it as we get to discuss it again next time. I'll talk about the mores. I just check through the tutors and the 10 teachers. We see what they say because it seems just these researches from any other source might give us something different. So on question 12, we are saying the best one we can pick is D there. If there's someone with a different opinion, please feel free. And then number 13 is saying, in case of threatened abortion, the fetal heart is usually seen on ultrasound, cervix is dilated, there is history of passing tissue per vagina, patient need immediate evacuation, and no need to give anti-D to rhesus negative mothers. Which one do you think is true for this one? Sorry? Okay, the fetal heart is usually seen. Yeah, that is true. And then B, cervix is dilated. This is not true unless maybe in inevitable. And it's in inevitable where we do immediate evacuation because there's nothing we can do here. The child will come out. Hmm. Now, so the best option is A. Yes, doc. All right. So 14 is saying missed abortion may cause one of the following complications: bone marrow depression, rupture uterus, high positive serum beta HCG, skin allergies, coagulopathy. Any thought on this one? Why, doc? Why do you go for that one?
think one of the complications of this misadoption is GIC and the requirement of
Okay. So, just to understand what happens in a missed abortion, the fetus has died or failed to develop, but the mother doesn't even really know. Okay. The pregnancy tissue is going to still be in the uterus, but the child has died. And what is going to happen is that because you have got this tissue for a prolonged time within the uterus and the mother doesn't know, thromboplastic substances are going to start to be released into maternal circulation. Those are factors that cause uh, coagulation. So there's going to be disseminated intravascular coagulopathy, clotting. And once you've used up the clotting factors, later on you are going to have bleeding. So that is what happens because of the prolonged period of these contents, the returns or the contents of a dead uh, ch- embryo or fetus. They are still there for a long time. The body responds by producing these thromboplastic substances. Number 15, regarding menstrual abnormalities, primary amenorrhea is failure of menstruation to occur by the age of 12 years. Fibroids are the most common cause of heavy menstrual bleeding among adolescents. Metrorrhagia refers to prolonged menstruation. Oligomenorrhagia, Oligomenorrhea refers to menstrual cycle length of greater than 35. Mullerian agenesis is a common cause of secondary amenorrhea. Any thought on this one? Any thought from anyone? Sorry? Why do you go for a doc? Why a?
I think the,
Sorry?
I think the,
Would you love to explain why?
so I was thinking the reason why I would not go for A is because I know I can be physiological and pathological. So physiological amenorrhea what can be like in the case the option what can be below the flow where the 12 months that can be physiological or can be pathological. But when they say primary amenorrhea, from what I was reading, they were told me to say it means that your amenorrhea is coming as a result of a defect uh, for example, things like vagina, area, things that are supposed to lead to menstruation, idea in the organ itself, but they are not happening. That's what refers to primary amenorrhea. So that's the reason why I would not go for it. Then menorrhagia, I was thinking it's having mechanism between the normal regulation and injury. And for the menorrhea, I was thinking it reduced menstruation, not increased length. And for the moreover and agenesis, I was thinking it's a cause of primary amenorrhea. That's the reason why I named it. But I'm not quite sure. Yeah, that's the reason.
Okay. Uh, so primary amenorrhea is you look at the age, but besides that, you also look at the development of the physical characteristics. For example, in females, if they reach 15 years and then they don't have any menstruation, and then they have got normal physical characteristics, that is primary amenorrhea, or if they reach 13 years with no secondary sexual characteristics and then they don't have any bleeding, that is still primary amenorrhea. So besides looking at the age, you also look at the development of the secondary physical characteristics. If they are not there, then it drops the age. If they are there, then at 15. Fibroids are not really the common cause of bleeding. Yeah. And then the commonest is because of the hypothalamic pituitary ovarian axis being immature. And then for metrorrhagia, as the doc said, it's bleeding between. Oligomenorrhea is actually infrequent menstruation. Since they're infrequent, it means that the period becomes prolonged, so it goes longer than 35. Then Mullerian agenesis, these are just the problems with the development, especially with the vagina. So D is a good option for here. Okay, when you look at these menstrual problems, you have got problems of frequency and problems of volume. Frequency is how often are you menstruating as a lady. The normal is 21 days to 35 days. That is eumenorrhea. And then if you are someone is bleeding so frequently for fewer than 21 days, that is polymenorrhea. And then infrequent menstruation more than 35 days, that's oligomenorrhea. For problems of volume, you have got menorrhagia. This is excessive, greater than 80 mils. Okay. The normal is 10 to 35 mils for a period of 3 to 7. So either greater than 80 mils or greater than 7 days. And then hypomenorrhea is scanty menstruation. So there's only little blood someone is losing in the menstrual cycle. Amenorrhea is no menses. Metrorrhagia is bleeding between. And then you have got dysmenorrhagia, which is painful. Okay. So that's why the best one we can pick here is D. 16 is saying, what blood test would confirm the diagnosis of menopause in a 51-year-old woman who presents to you with a complaint of amenorrhea for 1 year? FSH, estrogen, testosterone, HCG, prolactin. How can you confirm menopause? Anyone to help with this one? Sorry? There's a doc who said something. Can you just repeat? Why?
As someone, as a woman, what was menopause? Whatever is of this age,
Okay. So is it like the one that you use to diagnose menopause?
I think so.
Actually, that drop in estrogen production, what it does is that it doesn't stop the hypothalamus from releasing follicle, actually the anterior pituitary gland from releasing follicle stimulating hormone, which is the negative feedback. So you look at the levels of follicle stimulating hormone. If they are elevated, especially greater than 30 to 40 international units per liter for a period of 12 months or 1 year in someone that is over 50 years, then that is going to be a confirmation. Okay, so you are going to be looking at follicle stimulating hormone, but what has decreased is estrogen. But for the diagnosis, you actually look at follicle stimulating hormone, because this drop in estrogen when someone reaches menopause makes it impossible to have a feedback inhibition on the pituitary gland to release follicle stimulating hormone, and so it's going to be high. I don't know if that makes sense. Or greater than 30 to 40. Yeah, greater than 30 to 40 international units per liter. Number 17 is saying amenorrhea following postpartum hemorrhage is most likely due to Asherman syndrome, Cushing syndrome, Sheehan syndrome, Fils-Hugh-Cute syndrome, Meyer Rokitansky Kuster Howe syndrome. What do you think? Amenorrhea after PPH is mostly because of what? Yeah, Sheehan's. So if someone bleeds too much, it means that there's actually going to be, because of that bleeding a lot, there's a problem because there's going to be decrease in blood supply to the pituitary gland. Yeah. So that leads to hypopituitarism, and then it means that there's going to be deficient of gonadotropin secretion from the pituitary. Which ones are the gonadotropin? It is FSH and luteinizing hormone. Since these guys can't be stimulated, released, they're the ones who cause ovulation and the ones that cause maturation of the follicles. So that causes amenorrhea. Number 18, regarding congenital anomalies of the female genital tract, septate uterus can cause recurrent second trimester miscarriage. Double uterus results from failure or fusion of mesonephric duct. C. Longitudinal vaginal septate septum commonly causes primary amenorrhea. D. Imperiforate hymen results from failure of canalization of the vagina. E. Biconate uterus is the leading cause of female infertility. Any thought on this one? Any thought?
So,
Why do you choose that one, Doc?
so in the above explanation you gave, I saw something like the causes of second time abortion when the time is expected to pass.
Okay. So, okay. So that's one thought from the doc. Is there any other thought? Any other thought?
Also,
Yes, doc.
I also think it's because you said most of the causes of this second trimester miscarriages are anatomical anomalies of the prostate. I've also excluded C because something is supposed to be transverse vaginal septum for it to cause failure.
Okay. How about D? Imperforate hymen results from failure of recanalization of the vagina. What do you think about that one?
Yeah, it doesn't result from the canalization. mtoto the hymen is there. So it doesn't result from recolonization is happening before the interface hymen. Interface hymen, I mean.
Would you just say that again? Okay. So I think there's one doctor that explained for the abnormalities that result in the primary. What's the question even? Yeah, these miscarriages. Mm, we had actually mentioned that in the second trimester, the abnormalities with the uterus are actually going to be, that is from deuters. In the second trimester, problems to do with the uterus, the developmental problems are the ones that will be a biggest problem. Because for first trimester, the biggest problem that causes miscarriages is actually the chromosomal abnormalities. Okay. Double uterus results from failure of fusion of mesonephric duct. And then for this option, the uterus develops from the Mullerian duct. Mullerian duct is also known as the paramesonephric duct. So a double uterus is going to result from failure of fusion of the mesonephric duct. Okay, the mesonephric. So double uterus results from, this one is saying double uterus results from failure of fusion of mesonephric duct. So a double uterus is going to result from failure of the complete fusion, of course, of the Mullerian ducts, yeah, which are involved in the development of the reproductive tract. So that statement, oh, it has said mesonephric. So it's false because it said mesonephric, because the female reproductive comes from the Mullerian or the paramesonephric. That's why that one is not true. And then C, saying longitudinal vaginal septate common causes primary. What's one this one saying? Longitudinal vaginal septum commonly causes primary amenorrhea. So the longitudinal vaginal septate is going to divide the vagina vertically, like from up to down. So it will really not block the outflow from the cervix. So it might not really cause amenorrhea, no bleeding, because you can still bleed. Because this one, the problem is coming from up to down. There's no blockade of the cervix. This saying imperforate hymen results from failure of recanalization of the vagina. So an imperforate hymen is a failure of canalization of the hymen itself, which is going to be an opening of the vagina. Not really the vagina itself, as this option is saying. So if we say imperforate hymen is failure of the hymen to canalize. Actually, the hymen and the vagina comes from different places in biologically. And then the last option, by cognate uterus, is the leading cause of female infertility. And that is really not true. The leading cause of infertility is not really these or developmental problems, but in anovulatory disorders. Yeah, where someone is failing to ovulate. I, I don't know if this is okay. Okay, we are almost there. Just two questions. Which of the following is the commonest cause of miscarriage in the first trimester? cervical incontinence, chromosomal abnormality, thyroid dysfunction, uterus biconis unicolis, and phospholipid syndrome. Any thought on this one?
No.
Okay, yeah. So for this one, the biggest problem is actually chromosomes. In the first trimester, it's the chromosomes that are a problem, so abnormalities. The last question, the most common symptom of cervicitis, inflammation of the cervix, is dysmenorrhea, bleeding per vagina, leukorrhea, infertility, pruritus. What do we think on that one? Okay, so in cervicitis, when there's inflammation of the cervix, the common symptom is going to be the discharge that is going to be coming out because of inflammation. And the discharge is going to be having mucus. It is greenish or yellowish. It has got a very bad smell. So that is the symptom. That so what's that symptom called? It is leukorrhea or leukorrhea. That is the discharge that is coming from the cervix.